I'll also be timing myself. Can everyone in the back hear me okay? Good? Okay. Do that right? Okay. There we go. Okay. Okay, today I would be showing you some slides of my trip to Italy if I had gone, which I haven't. But instead, I'll be talking about cancer cachexia, current and future therapies. This is a topic that is near and dear to my heart. Of course, I've been studying it for a little bit now, and it is a under-researched, undertreated, and surprisingly very prevalent condition. So I imagine a lot of people haven't, I'm sure some people in here have heard of this condition, but I'm almost certain the majority have not. So I want to first define it. The second aspect, I want to show the impact of cancer cachexia. If you have left with nothing today, I hope that would be something you leave with, is that this is something that is very important. I will then go into the multifaceted syndrome, a multifactorial syndrome that is cachexia, and trying to get as much as I can within this talk a picture of how complex this can be. And then discuss the past and current therapies. And I'll kind of breeze through that for reasons I'll talk about here in a minute. And I want to go into future therapies. I think this is something that the crowd in here would be very excited to hear about more so than the past, which have not worked. So, and model systems, if you're interested in that, please come to my poster. So, all right, so first I want to start by talking about cachexia and defining it first. This is a paper in 2008 by Evans and kind of a who's who in 2008 of cancer cachexia research. This picture defines what a patient may experience if they have cachexia, and I think it's important to show that and then also kind of go into what are the implications of this and how does it start, and we'll start with that first. So when they define cancer cachexia, they define it as a multifactorial syndrome that is defined, that ultimately leads in wasting of the body tissue. And the multifactorial syndrome starts with, and can involve anorexia, a loss of food intake, or reduced food intake, inflammation, which is a very critical component, but also a very targeted aspect of the disease, or at least for therapies currently. Insulin resistance, a more accurate way to describe this would be metabolic derangement. It's not just insulin that's deranged, it's other things such as ghrelin as well. Anemia. All these can in some way contribute to the different compartments of the body, fat mass, and also muscle mass. Anorexia can contribute to both of these as well as inflammation. Insulin resistance seems to be a little bit more specific to muscle, and so is anemia. Now, both of these certainly contribute to weight loss, but muscle is a little bit more specific, or a lot more specific to ultimately the functionality of the patient that has this disease, their weakness and their fatigue, as well as anemia. In this paper, they went about describing what would be a diagnosable criteria for someone who has this disease. And that would include at least 5% weight loss over a 12-month period of time, or less than 20 BMI, which may not be the best criteria, plus 3 of the 5 symptoms on the right-hand side, which adds to the validity of it, which is decreased muscle strength, fatigue, anorexia, a low fat mass index, and also biomarkers that are heavily associated with this condition. These include things such as inflammatory markers, C-reactive protein, IL-6, anemia, and also low albumin. And of course, when it comes down to it, the most important tissue that we're seeing change is the muscle tissue. So this is something that's a target and very important to restore, or not restore, in some cases restore, but prevent from wasting. So then in 2011, Kenneth Theron, who actually passed away last year, he's the most cited researcher on this topic, went about defining it with a group of other MDs, discussing what is cancer cachexia, because cachexia is not just in cancer, it's also in COPD, kidney failure, chronic heart disease, and also other conditions such as AIDS. So it's not just in cancer, but this specifically defined it in the context of cancer. And they went about providing a staging criteria. So the first stage of the disease is pre-cachexia. This is where you experience less than 5% of your body weight loss, but greater than 1% of body weight loss. You also can experience a reduced food intake and also metabolic derangement. But in order for you to get to the criteria of being defined as cachexic or having cachexia, you want to at least have 5% of your body weight loss. You also can have other criteria such as at least 2% of your body weight loss with a low BMI or being diagnosed with sarcopenia. This is also associated with reduced food intake, but also the inflammatory conditions seems to be occurring at this point. And then refractory cachexia. This can have varying degrees of cachexia or wasting. certainly more than 5%. But what's important about this, the most important about criteria for to be defined as refractory, is that antineoplastics no longer work. In addition, it's generally believed that when you hit this criteria, you will no longer respond to therapy. You do not have hope at that point. And if I have time, I will at least show the possibility that there may be some hope. So I wanted to define, because I know this crowd is probably very familiar with things such as caloric restriction, things such as with starvation, or a fancier or nicer term is fasting. And so these are distinctly different from each other. Cachexia involves weight loss, muscle mass loss, fat loss, anorexia, systemic inflammation, all the way down the board with insulin resistance, low gonadism or low hormone levels, anemia, and functional impairment. Whereas starvation and caloric restriction only really fit the criteria of reduced food intake and body mass loss. Sarcopenia has some unique properties to it. I can't go into too much detail here, but infection is unique, is that infection actually replicates many of the criteria that cachexia sees. And I wanted to highlight that because you'll see why that's so important in infection. It has such a great impact. Now, this is a slide that is important to kind of nail home, and this is the one that I want everyone to at least take home, if nothing else. Everyone knows that cancer is the second leading cause of death, but 30 to 80% of all patients are going to experience weight loss if they have cancer. And that varying degree of 30 to 80% has to do with tumor heterogeneity. But 60 to 80% of advanced cancer patients, those who have metastases, will experience it. So more than half, certainly, of all patients who are going to have advanced cancer will experience this condition. Weight loss is also a prognostic factor. The first study I'm going to show you has over 400 patients. The second one I'm going to show you has over 700. And what they looked at was different criteria for what would be defined as cachexia. And they actually went about breaking down individual criteria, such as just weight loss and degrees of weight loss, such as C-reactive protein, low albumin levels, low hemoglobin, and different defining criteria based on different studies, because people have attempted to define it differently. And what you find is, I was just going to highlight this section, but I want to at least show that if you fit any of these criteria, your prognosis is worse. And a lot of times, this is actually halving your survival in a lot of cases. Here is another study with 700 patients, and what they did with this, which I think is unique, is they actually staged it in two different ways. They took this group of patients, there were 700 patients, and those who were cachexic, which is greater than 5% weight loss, that was it. And you see that those who have cachexia had worse survival. In fact, although it may not represent it here, it's actually a halving of survival. And in here, what they did is they used a more refined criteria to show across not just weight loss, but also advanced criteria, such as greater degrees of weight loss as you go from pre-cachexia, cachexia to cachexia and refractory cachexia. And you see as the weight loss becomes greater and the criteria becomes more refined, you see that the prognosis gets worse. Weight loss adversely affects your ability to receive, tolerate, and respond to therapy. If I had time, I would certainly love to go into the multifaceted reasons for that, but it certainly does matter. And one of the most important parts of this is that 20% of all cancer patients who get cachexia or get cancer and they die from cancer, they're going to die not from cancer so much as they will die from actual cachexia. And so this is certainly something that needs study. It needs more advancement in treatment. And this is a study all the way back to 1932 that actually showed the prevalence of cause of death for certain types of criteria when someone had cancer, certain types of cancer like bladder, breast, so on and so forth. And this was an average of about 20%. And this, of all cancer patients, died from this condition, cachexia. And it has not been refuted all the way back for almost 80 plus years going on still. And there's no standard of care for this condition. So although there is some things that have been proposed, nothing has actually been shown to efficaciously work all the way through multiple clinical trial stages, all the way through 3. So this is a multifactorial syndrome. Of course, you start with cancer. That's the prerequisite. You have to have that first. But you also have inflammation, addition of reduced food intake. And these are integrated together. They're not isolated. This is very dynamic. In fact, if you affect one, you're likely affecting all other aspects, at least to some varying degree. Ultimately, this is leading to a muscle weight loss, and muscle weight loss is going to affect all these other aspects as well. And this is a paper back in 2014, Nature Review paper on cancer, that basically shows that organs not only affect skeletal muscle, but skeletal muscle affects organs. It's very dynamic. So I'm going to breeze through this because all these have failed. But I want to at least show maybe some rationale why they have, and also kind of talk about some therapies that kind of seem counterintuitive, but I'll highlight the ones that are the most studied ones, and maybe of most interest to this group. So the different categories are nutritional-based approaches, appetite stimulants, which ultimately gets to consuming more nutrients, anti-inflammatories, and anabolic agents. So a high-calorie diet, of course, these patients are in a caloric deficit. They're losing weight. They have an average about 250 to 400 calories per day deficit. This is the most common recommendation given for patients who have this condition, is to just eat more. The pros of this is that it can, in some circumstances, been cited to improve quality of life. But the con is that when you gain weight, especially when you lose weight, and this is not just specific to cachexia, you're going to gain mostly fat. You're not really restoring the muscle tissue, and at the very best, you're just attenuating loss, although that's the minority of the reports shown. So you're just gaining mostly fat. A high-protein diet, this makes a little bit more sense. This is providing some substrates for active tissue, wound repair, enzymatic activity, and the actual tissue that you're trying to attenuate loss or cause some type of rebuilding. But the problem here is that there's little evidence to support this, and the ranges for optimal dose range pretty widely from 0.8 grams per kilogram to 2 grams per kilogram. For me, as someone who's 245 pounds, maybe I've lost some weight, I don't know, but that would range from 95 to 220 grams of protein, if my math is correct, and that's a pretty big difference. So we certainly don't have a good criteria yet for that. Progesterones, this is actually, besides the most studied of the drug categories, this is first considered oral contraceptive, of course, progesterone, believed to work through neuropeptide gamma, which affects food intake and other things such as fat storage. It is approved, one drug that is approved as a progesterone is called Megace. It is currently approved for AIDS patients who have cachexia, but is certainly not approved for cancer cachexia patients, and is not considered something that should be considered for treatment. At least it's not shown to work through phase 3 clinical trials. Ghrelin mimetics, ghrelin is a hormone that works acutely in response to hunger and appetite. So let's say I don't eat an entire day. If I'm on standard diet and I don't eat for the entire day, or say I eat 3 or 4 meals a day, and then when I get around meal 2 time, I don't eat, my ghrelin is going to be elevated, and that can stimulate hunger through the hypothalamus. So they're trying to mimic that. It certainly can help improve patients who had cardiac cachexia, but it has not obviously been approved for cancer cachexia patients, and also there's other consideration that must be kept in that some cachexia patients have ghrelin resistance, such that giving this may not actually help at all, or likely to help very much. Cannabinoids, this is just seems obvious to at least try this, because anyone who's been a teenager at one point probably smoked marijuana and maybe got the munchies. So this has also not worked, although they have tried to isolate the individual compounds out of marijuana that may actually have beneficial effects. So maybe there may be a different way to approach that, but this has not worked. Corticosteroids, I will at least say this is an immune modulatory molecule for its anti-inflammatory properties, but it can certainly affect your food intake by improving it indirectly. It's not usually something that you're given for food intake. But, so it can improve appetite, but it has many, many side effects, including elevated blood glucose and worsening of affection. And there's a lot more. You can literally go online and just spend your day reading them. Anti-inflammatories, of course, we talked about corticosteroids. NSAIDs certainly has not shown to work yet, although they have been used in combination with other things to try and reduce some of the inflammatory components. COX inhibitors such as Celebrex, again, hasn't worked. Omega-3s, I will spend a second here and show that omega-3 seems a bit more promising in that it affects not just one facet, it affects multiple facets of the condition, increasing pro-inflammatory cytokines and proteolysis-inducible factor. It's non-toxic. It has shown in some instances to target multiple aspects of this multifactorial syndrome. But it's mixed results, and there's heavily cited to say it's insufficient evidence to really show that this could be used as a recommended therapy, although it's non-toxic, and it seems maybe not advisable to say not to use it. So maybe it's something that if someone's on a well-formulated diet, they probably have sufficient levels of these. I won't waste my time on that. So anabolic agents. So the first one is selective androgen receptor modulators. This was kind of hyped a while back. for potentially replacing testosterone in the fitness community as an anabolic agent to upregulate or to bind directly to the androgen receptors on muscle. I'm sure many people, with this therapy or SARMs, Endosarm and Osterome, I know I mispronounced the second one. What's positive about this is they've actually shown to increase muscle mass, which is great. They've successfully completed phase 2 trials, and we're waiting to hear back from phase 3 trials. They haven't come out yet. They're actually supposed to come out in early 2017, which is now. So we'll wait and see what happens with that. Testosterone is improved. Fatigue hasn't worked. Myostatin is elevated in these patients. You see elevated levels of myostatin, which is a blocker of anabolic growth of the muscle. But it's all preclinical evidence at this point. It looks super promising, but it's all preclinical. Insulin has actually been used, which is kind of surprising. It actually, in this study, improved survival. That's because the patient was probably going to die from cachexia and actually gain some weight and survive a little bit longer, but this is certainly not something that anyone would probably recommend in this audience to give a patient. So when you talk about cachexia, you're talking about, with these targeted therapies, you're talking about currently 100 clinical trials over all the years of study on cachexia, and there's no standard of care, and you have to ask the question, why is that? Well, it's very complex, as I try to drive home. It's difficult recruiting patients, and it's also difficult following patients. I've worked with human population before, those with debilitating conditions such as stroke, and I can say it is absolutely difficult to do that, to keep up with patients and to make sure you get the data you're trying to get. The underlying pathology is not completely understood, although we know a lot. We don't know everything. It's kind of like a ketogenic diet. We know a lot, but we don't know everything, so this is right in that same category. It is unlikely that a monotherapy will ever work. This is pretty much cited in any high-level paper. This is what they leave the paper with, is monotherapies aren't going to work. We need to do multifactorial therapies, and that's just the nature of medicine. You start with a single therapy, and you try and see what it can do, and you may add it to other things, but that's where we're at. So a multifactorial syndrome will likely need a multimodal approach. Proposed successful cachexia treatments. This is a list that I've accumulated that I feel like kind of hits home and what could be a good way of approaching what is a good therapy for cachexia. So acceptable toxicity, ideally none. That's the approach of our lab, is non-toxic therapies. We also likely want to target the tumor. At the very worst, you want to not have a proliferative effect on the tumor. So it would be great if any therapy you're using to attenuate muscle loss, inflammation, or reduce food intake also targets the tumor. Normalize systemic inflammation, which inflammation can actually play a pretty critical role in every single facet of this, maybe more of a critical role than some of the other components do. Normalize dietary intake, or wait till you've reached a body weight that you feel comfortable with maintaining with patients. I include that because I know caloric restriction has its place in especially cancer, but I would certainly say that this is also something that has to be kept in mind when losing too much weight. And then also, you want to improve quality of life. That can't be negated when you're talking about patients with a condition that severely affects quality of life. Weight loss is an inverse relationship with quality of life in patients with cachexia. And ultimately, the approach you give, you want it to target every single aspect of this. So, what are some untested metabolic therapies? And this is hypothetical at this point. I will show you some preclinical evidence and some included for physical activity of human evidence. But some of these is hypothetical, but this is something I think may be of interest for future, and it's something we're looking into currently. This includes a ketogenic diet, ketone diester, which is a ketone supplement that's not currently available for regular consumption. Physical activity, aerobic and anaerobic, although there's some caveats with that. You don't want to overdo it when you have systemic inflammation. You might not be able to recover. I wanted to say that now before I potentially forgot to when I'm rushing at the end. So the ketogenic diet, where's its role in tumors? Well, I don't probably have to belabor this point. It's already been talked about extensively in its potential role. In our model, but I do want to highlight the models in the literature right now, the preclinical evidence at this point that could potentially work in cachexia models. And so it's interesting that Angela actually did some work with this model of GBM. Well, what's interesting about this, if you inject this into the flank, you can actually cause systemic metastasis. And that systemic metastasis we have currently studied the metastasis of the animal seems to be required to induce a cachexia syndrome. And it does, and it does so in a way that models the human condition, which is very interesting, and this has improved survival in the animal model previously from previous work. Tisdale showed a paper in colon cancer model back in 1987, I believe that's the date, yep. And they showed that higher levels of MCT and BHB, or beta-hydroxybutyrate, included in the diet. If you look here on the tumor weight, you see that's 1.2. As you have higher levels of MCT in the diet, or add beta-hydroxybutyrate, MCT at 80%, and add beta-hydroxybutyrate, the tumor weight just goes down in a linear fashion. Ketogenic diet for lung cancer. In Lewis lung carcinoma model, what they found was that when you have ketogenic diet, you may reduce tumor burden. What's interesting about this, though, is when you reduce tumor burden, you actually cause muscle wasting as well. So they added some protein to the diet, and what happened with that is it didn't attenuate as much, not significantly, although it is reduced here. It did attenuate tumor weight loss, but it actually attenuated muscle weight loss as well. So it's pick your poison there. Ketogenic diet diminishes tumor growth in pancreatic cancer model, which I think is a fascinating study because, well, the same studies here I'll show also for muscle as well. Tumor weight was reduced, as you can see there, and there's also been a few clinical studies just showing that the diet can be safe, feasible, and improve quality of life. Ketogenic diet for inflammation. The first talk of the whole entire conference addressed that. Can reduce inflammatory markers directly via BHB. Ketogenic diet can, in 2 studies, shown to reduce inflammatory molecules compared to a regular diet, although it involved weight loss, so that may be a confounding factor with those results. And ketogenic diet facilitated, so Dr. Scheck's work has shown that you can actually cause improve T-cell efficacy in the tumor microenvironment. But Walter Longo actually spoke about this yesterday, that also is something he found as well, and either fasting or a fasting mimicking diet in breast cancer model. Muscle wasting, I'll rush through this. These are the same studies that had shown cachexia. So in these studies where they showed reduced tumor burden, they're also showing improved muscle mass with these same therapies, which is great because that means it's multimodal. And it makes sense as well. The tumor weight has gone down, but you also see that for lean body mass, you see that the highest percentage of MCTs and BHB retain the most amount of muscle mass. Again, the lung cancer study, which I already kind of addressed, the pancreatic study I also addressed compared to standard diet, you see it as elevated skeletal muscle mass. And there's a belief that when you go, you calorically restrict or you go into some type of starvation or ketogenic diet, that you can actually attenuate protein loss in a catabolic condition. I'm going to breeze through this. This is a ketone ester, 1,3-butanediol acetoacetate diester. It was synthesized by my professor, Dominique D'Agostino and Patrick Arnold. When ingested, gastric acids cleave it, producing acetoacetate and 1,3-butanediol. 1,3-butanediol goes to the liver and then it converts to beta-hydroxybutyrate. It does so in a dose-dependent manner. I'll say that acetoacetate has reduced cancer cells. This obviously is not the diester that was used, but they show that acetoacetate can reduce cancer cell growth. BHB and acetoacetate reduce pancreatic tumor growth and cancer-induced myofibril degradation. It's actually pretty interesting how it blocks that mechanism. Thank you. Ketone ester extends life in our model that actually we found out is in fact cachexic, and some work from Angela has shown that it has reduced many pro-inflammatory cytokines when ingesting the ketone ester. For muscle wasting, there's an interesting study back in 1988, I believe, by Nair, showing that when you give IV BHB to the same level which you can induce via dietary therapy or supplemental therapy, you can actually promote leucine, or it reduce leucine oxidation. Leucine can work as a signaling molecule to promote muscle protein synthesis. Once it's oxidized, it may not directly stimulate in the same exact way. So reduce leucine oxidation, but also, which you can't really see here, but here is just lines showing marker of muscle protein synthesis. It goes up in every single patient who underwent this IV treatment. Acetoacetate causes muscular regeneration in a rodent model of muscular dystrophy. This is one of the most fascinating papers I've ever read on acetoacetate. And I'll just highlight that it says, in the paper, it went about explaining how it induced muscle cell proliferation, upregulated IGF receptors, and partially antagonized myostatin. Physical activity is, I believe, a no-brainer and should be recommended. Should not probably be overdone, though. I won't read all these and just show that one cool aspect is it improved vascularization in tumors and breast cancer models, and they're also working with humans now. And this is out of Lee Jones' work, who's done a lot of work on this. He's now at Memorial Sloan Kettering. And this is the last thing I'll say, is that in refractory cachexia, it's generally believed you can't actually, there's no treatment that will work and probably believe that it will never work. However, there was a paper, I'm just going to skip all this, there was a paper that came out that showed that 15% of all cancer patients in the last 3 months of death, when they are refractory, can actually gain muscle. So what they did is they looked at those patients who gained the most amount of muscle and lost the most amount of muscle. And what they found is, you can't really make it out here, but that 5% of those who had gained the most amount of muscle and those who lost the most amount of muscle, they looked at different things that would indicate why that happened. And the only thing that really popped out to them is that when they actually gained muscle, they had stable disease, whereas those who lost the most amount of muscle had progressive disease. So if there's a way to attenuate the cancer condition, there may be a way to actually get in at that time frame and actually promote muscle growth, or in this case, muscle growth, or at least attenuate it. So with that, I would like to thank everyone in our lab. Our funding source, Civation, has been very generous and very helpful. Our whole entire lab, Dr. Angela Puff, who put on this conference, Dr. Nate Ward, who's incredible, has been very helpful, Janine DeBlasi, who's right here, is an undergraduate absolute star, Chris Rogers, who's in the back over there, Shannon Guy, who's now at Epigenetics Foundation, I really appreciate that, Dr. Chilla Ari, who's also in the back, Melissa Ramirez, who's not here, and Dr. Dean's lab and the staff of the Vivarium who've helped me. Any questions?